started at this point. Thank you so much for joining us here today. Indeed, this is our latest media briefing on important healthcare issues in the news. I'm Dr. Zacharias, President of the Ontario Medical Association, which represents more than 43,000 physicians in Ontario. In the coming months, Ontario will likely face the triple threat of respiratory illnesses. We are already seeing an early start to the flu season and the resurgence of a viral disease in children known as RSV, while COVID-19 is still circulating in our communities. This comes as our healthcare system is already under immense strain. Ontario's doctors are urging the public to ensure they get vaccinated for the flu and to also get their COVID-19 booster shots. We're also calling on the government to act on the OMA's 3 solutions that could be implemented now to ease the burden on the healthcare system. For the last 2 winters, we've had very few cases of the flu because we were following public health measures to prevent the spread of COVID, like mandatory masking and physical distancing. And so this is the first flu season since the pandemic began that we don't have those same public health measures in place. And that's worth paying attention to. What happens also in the Southern Hemisphere is also worth paying attention to because it's often a good indication of what we can expect here in Canada when it comes to the flu season. And what we know is that Australia had its worst flu season in 5 years. The flu arrived early and it was severe. Children were hit the hardest. It's worth noting that vaccination rates were also low in Australia this year, around 35 to 40%. And in Ontario, we're already seeing more flu activity than last year. So the flu arrived more than a month earlier than usual. And for example, in the week of October 23rd, there were 866 lab-confirmed flu cases in Ontario, compared to 0 in that same week last year in 2021. And cumulatively, we've had 1,544 flu cases recorded, and compared to last year, that number was 7. So it's arrived early, and our numbers are much higher this year than they were at the same time last year. So we need to be prepared. Historically, emergency departments visits and hospitalizations due to respiratory illnesses rise in the winter. We know that. And emergency departments have already been experiencing record volumes in recent months, on top of the doctor and nursing shortages and burnout. We're also seeing a spike in RSV, or respiratory syncytial virus, a common respiratory infection, as children previously shielded by COVID-19 health restrictions are being exposed to it for the first time. RSV usually circulates from November to March, but also arrived in Ontario about a month earlier this year. And then meanwhile, we are still in a COVID pandemic. Almost 10,000 new cases were confirmed the week of October 30th, and hospitalization rates are higher than they have been since February. And so that is our current state. And I just really wanted to outline that in brief before now I introduce you to our panel of experts who will talk about these issues in more detail. So first of all, Dr. Vinita Dubey is the Associate Medical Officer of Health for Toronto Public Health. Welcome, Dr. Dubey. Dr. Rod Lim is the Medical Director for the Pediatric Emergency Department at Children's Hospital in London. Welcome, Dr. Lim. And then Dr. Howard Ovens is an emergency physician at Sinai Health who has an extensive background in provincial policy work. Thank you so much, Dr. Ovens, for joining us this morning. So we're going to start with Dr. Dubey. Please tell us, Dr. Dubey, from your public health perspective, why is the flu shot especially important this year? And how is flu expected to circulate in Ontario this year? And should the public be considering masking or taking other public health safety precautions? Over to you, Dr. Dubey.
Yeah, I mean, I think you've laid it out very well, noting that the flu is circulating. It is here. It's in our province, but it's not too late. We are not yet at the point of widespread activity, but we've certainly seen a significant number of cases compared to this time last year. And if you look nationally, 50% of all cases that have been reported have been in children. So we have to really keep that in mind for our children, especially because younger children, children 0 to 5 years of age, can be at very high risk for getting very sick from influenza. And that's why they are actually strongly recommended to get the vaccine. And so there still is time for adults and children 6 months and older to get that protection from vaccination. And that would be from getting the flu vaccine, but also the COVID-19 fall booster dose, which would be the bivalent booster in adults. And for 5 to 11-year-olds would be a single booster. And of course, getting our youngest children vaccinated against COVID-19 as well. As we reflect, I think all of us are participating in a fall that we haven't seen for the past 2 years. We are participating in our lives similar to as we had before the pandemic started. And this means, unfortunately, that respiratory viruses can spread easily, but there are things that we can do to prevent the spread without having to implement extreme measures. And so as we're learning to live with these viruses, the things that we can do to prevent infection include, first and foremost, getting vaccinated, because that really is our ongoing measure of protection that we can continue to have. You mentioned wearing a mask, and of course we can wear a mask, especially in indoor settings, especially if they have poor ventilation or if they are crowded. We know that a mask can protect us and others from the spread of respiratory viruses. That is something that we have learned through the pandemic. We also ask people to stay home if they are sick. Parents can do an online screening tool to find out which symptoms does my child have, that they're best off staying home so that they can recover, but also so that they don't ongoingly spread illness to others. And the same goes for adults as well. Speaking of ventilation, what we've learned through the pandemic is let's pick well-ventilated spaces indoors and stay outdoors as much as we can as well. Washing our hands often is going to be very key. And then keeping surfaces clean. That again is another way that we can help to prevent the spread of viruses like influenza.
Thank you, Dr. Dubey. I appreciate not only emphasizing the situation, and it can feel bleak, the description of it, but so many things that we can do. Really appreciate your perspective. I now would like to turn things over to Dr. Lim. Of course, Dr. Lim is Emergency Medical Director for the Pediatric Emergency Department at Children's Hospital in London. And so, Dr. Lim, from your perspective, how do respiratory illnesses impact children specifically, kind of building on Dr. Dubey's comments there? What are we seeing now in terms of RSV, and how is the pediatric system coping with the pressures? Dr. Lim.
Thank you so much. And I want to reinforce a lot of the introductory comments that Dr. Zacharias provided and Dr. Dubey. We are definitely seeing a lot of what's been described on the ground. Right now, the pediatric system is under significant strain at all levels due to the amplification of these seasonal pressures. It's important to note that every year, we know children tend to get respiratory illnesses in the cooler months. And it's always a little bit of a challenge juggling capacity during those times. This year is extremely difficult. We are seeing viruses circulate at different times than we have traditionally. We had RSV even in the summer months, but currently we are seeing tremendous numbers of patients coming in with respiratory illnesses, whether it's RSV or influenza or COVID-19. It's a little bit of a perfect storm right now because of not only the numbers, but obviously we have a lot of manpower challenges that are faced in a lot of other areas and sectors. And on top of that, we've been having a lot of supply chain issues as well, which has added to the challenge of doing our job. So there's been a tremendous amount of coordination between different levels to try to manage this strain. But I can personally say that it's been an extremely challenging period of time, and I thank tremendously the healthcare workers that are continuing to show up and do the best we can to serve the population that we are asked to provide care for. This I sent a word out to parents. I know this is a time of anxiety after having lived through the pandemic over the past 2.5 years, and I know a lot of the news is concerning to parents, and I really thank them for the patience in order to seek out the most appropriate level of care as possible. And I know the supply chain issues are extremely distressing to them as well. Yesterday, I had a parent who tried everything they could to try to get their hands on some anti-fever medications. They tried grinding up pills, they tried calling multiple pharmacies, and I just know that personal stress to families is a real one, and my heart goes out to them, and I thank parents in this difficult time for their incredible patience and diligence to do their part to help as we get through this challenging season. I mean, the system is very difficult. Our emerge is only built for about 100 visits per day, and 2 days ago we saw 200. Yesterday we saw 180. We are being incredibly creative to try to see them in alternate care spaces and trying to provide the humanity that is necessary for anyone who wants to care for children. So again, just a tremendous shout out to all those people that are showing up every day as we continue together to try to challenge, to take care of these challenges that we're facing.
Thank you so much, Dr. Lim, and just our extension of thank you as well to you and your team there at Children's Hospital in London for showing up at work as I see you are even currently. We pulled you away for this media briefing, but you're in between shifts, and we just want to extend a thank you to you for your caring and expertise and compassion, and to all of your team there in London. I want to turn things over now to Dr. Ovens, also an emergency department physician. Dr. Ovens, tell us about the strain from your perspective on the emergency departments right now, how we expect it to worsen in the winter, and even maybe what the public needs to know about when they go to an emergency department and what to expect once they are there. Thank you so much for being here, Dr. Ovens.
Well, thank you, Rose and colleagues, for the opportunity to be here today, and thanks to the media for the opportunity to speak through you to the public as an emergency physician. And let me take a moment to begin by saying that nobody wants to come to the emergency department, and if you can avoid it, an ounce of prevention is worth a pound of cure. You've heard a lot today and a lot for years now about vaccination. I'm just going to add a personal note. Everyone I work with, emergency physicians, infectious disease people, critical care people, we're all vaccinated. Everyone we love is vaccinated. We believe in the vaccine, and there's a lot of inertia, and it's misplaced inertia. You should get out there and get the vaccine for you and the people you love, not just to protect yourself, but to protect those people around you. Despite everything you read in the news, our emergency departments are open. We have triage processes in place. And because of all the news, some people with real emergencies who need to see us are delaying and making themselves sicker and making the care that we need to give them more complex. My most important message is, if you have what you believe is a serious or even potentially life-threatening emergency, especially if you're over 30 and you have chest pain, if you're experiencing shortness of breath, if you're feeling faint or lightheaded and it doesn't pass quickly, if you're having severe abdominal pain, nausea, vomiting, we're here for you. And don't delay. Once you feel that you are having an emergency, please come to see us. If it's not safe for you to sit in a car, call 911. Having said that, if you feel miserable, but you don't have any of those serious symptoms, or if you're not sure if you have serious symptoms that require emergency attention, take a deep breath and think things through a little bit. You can get expert advice, although unfortunately many of our neighbors and fellow citizens don't have access to a family doctor. The majority of Ontario citizens have a family doctor, and often people haven't tried to reach their family doctor and would be surprised if they did that there is more access than they actually anticipated. And it is worth trying to call your family doctor's office or clinic and see what advice is available to you in what sort of timely fashion. If that doesn't work or you don't have a family doctor, we have an excellent service in Ontario called Health Connect. You can either go to the website or you can call 811 and get some information on how to manage the symptoms you're having and whether you need a trip to the emergency department or not. Once you get to the emergency department, if the triage nurse is not worried about you, and there are some long waits people are facing right now, we're sorry that anybody has to wait. Very long waits are really an embarrassment and something that none of us are proud of. On the other hand, if the triage nurse isn't worried about you, that is a good thing. And at least you can feel reassured that you're not in immediate danger. We are living in challenging times, and a lot of people are under stress and their tempers are short. And we see this in so many different ways, politically, socially, in road rage, and we experience it in emergency departments. A lot of people have left emergency care. I'm so grateful and proud of my colleagues who continue to show up every day. Just once, I'd like to see a headline saying, emergency staff showed up again today, continue to do their best under difficult circumstances. So remember, the people who are there in the emergency department are not the reason you're waiting so long. They're the reason you're getting care. Please be kind, please be courteous. We're doing the best we can. And with that, I'll hand it back to you, Rose. Thank you so much.
Thank you so much, Dr. Evans. Really appreciate your perspective, really appreciate your compassionate advice, and of course, your understanding from your lived experience of the situation. And indeed, a headline there about the gratitude we have for our colleagues who are showing up at work in very stressful and challenging times is warranted, absolutely. So thank you to all of our experts in the room, Drs. Dubey, Dr. Lim, Dr. Evans. We're now going to open it up to the Q&A session. I see many questions coming in on the chat. Fantastic. Our OMA's Emily English will be moderating this portion of today's briefing. Continue to put those questions in the chat. If we don't get to your questions in time, the media team will definitely follow up with you. You can also email media@oma.org. I know we'll throw that in the chat with additional requests for interviews of the topics that are coming out of today's media briefing. We would be happy to accommodate those. Also, we will have a recording of this session available later this afternoon. So I'd like to hand things over to Emily.
Thank you very much, Dr. Zacharias. The first question comes from the CBC's Chris Glover. Dr. Rod Lim, this question's for you. Can you describe for us what you're currently seeing in your emergency department? How unprecedented is this? Some children's hospitals are needing their patients to go to other adult hospitals. What is your hospital doing to deal with the rush in patients?
Thank you very much. Great question. We are definitely seeing what's being described in real time. So certainly we have record volumes. We have November will likely be the highest number in our history. We're currently seeing anywhere between 80 to 100% increase in our traditional census right now. So certainly the numbers are very high. Currently, we are seeing lots of young infants who are coming in with respiratory symptoms of concern around bronchiolitis. That is the most concerning age group that we do see, and we are certainly doing our best to manage that situation. So It's a lot of creativity and a lot of dedication to try to tackle this. The second part of the question in terms of transfer, that's a little more complicated. I want to remind people that most pediatric emergency care does occur in general emergency departments that are throughout the province, and they do an excellent job. As a tertiary level care, we provide care to the sickest patients, and we work in coordination with all of our partners in order to provide the right care in the right location. All levels are trying to coordinate very closely the increasing of capacity for pediatric patients in the province. As you know, there was some talk of some of the older pediatric patients to try to be managed in adult ICUs. That is something that is in very close discussion between the experts, between the system, in order to ensure that kind of care takes place in a very thoughtful manner. From our emergency department point of view, again, it's a lot of handling the diversions that occur. We really thank our regional partners. Just yesterday, we've had 2 areas that were on pediatric diversion because they actually went above and beyond their capacity for pediatrics and took additional patients to try to help the region, and therefore required us to be able to take some of those calls directly. So as you can see, there's just so much coordination and so much working together to try to manage the system, and I really thank very much all the levels that are helping coordinate this and continue to do so as we face challenging times.
Thank you very much for that answer. We have a question now from Len Gillis from Sudbury.com. I'm going to direct this one to Dr. Zacharias, who's the OMA president. Is it the feeling of the OMA that a masking protocol should be recommended, or would the OMA prefer to see masking profiles mandated in some situation where there is a risk of respiratory infection that's higher than normal?
Yes, so we, thank you, Emily. Thank you for the question. We do want people to consider wearing masks in places that are crowded, for example, in places where there are more vulnerable people, when it's difficult to keep that distance or not to have to avoid a face-to-face, then wearing a mask is very reasonable and encouraged. And we will continue to lean in to our public health experts as to where we are going with the advisement about mask mandates. And so in the meantime, we do have opportunity to make decisions for ourselves and our children based on our own health risks and the risks of those that we'll be interacting with and our comfort level around masking. We do have now the ability to make those decisions, but we need to be prepared to pivot. Our entire conversation today is around the increasing risk of respiratory illnesses, and we know that masks can protect there. So we will be continuing to lean into our public health expertise and public health experts and the advice they give us.
Thank you very much. And we have another question. This one comes from Holly Mackenzie Stutter, who's with the Canadian Press. She has some questions about the children's medication shortage. Dr. Rodlim, I'll direct them towards you. What are the main impediments to increasing the supply of children's Tylenol and other pain and fever medications, and how are they being addressed? And she's also asking if bilingual French-English labeling is one of the barriers.
Yeah, thank you very much. Again, to my knowledge, there are lots of people trying to work on this problem, and it's a complex one. The way the medications flow in and the regulations and whatnot, and how they reach different hospitals versus pharmacies and whatnot, is obviously a complex system, and one that we didn't really have to think about prior to our current challenges. Certainly, I among others, have read the news around the recent relaxation or granting of exemption of the of Tylenol and Advil to hospitals that was announced. That will certainly help with larger supplies. And my understanding is that if similar exemptions can be granted to pharmacies, that would alleviate some of the ability to import Tylenol and ibuprofen to pharmacies due to labeling initiatives. So I'm sure excellent people are looking into this, and we welcome any kind of creative solutions that will help provide these to families that are looking for it, because I know how stressful that can be for individual families that are just looking for a medication that can help alleviate some of the symptoms and provide some relief for their children.
Thank you very much for that answer. We have a question now for Dr. Vinita Dubey. Last year, flu vaccination rates were some of the highest that we've seen. How are things looking for this year, and are you encouraged?
Yeah, thanks for the question. Absolutely, we had a huge demand for influenza vaccines. We also didn't see a lot of flu activity, and some of it was related to our COVID measures. Some of it very well could also have been related to the vaccines, because what circulated last year, the influenza A strain, seems to be what's circulating now, and that certainly is in the vaccine. This year, we have seen people coming to get the vaccine, but not in the same robust way that we saw last year. And we have heard in general about vaccine fatigue. We've seen that also with a COVID booster, a fall booster. So I think the main message, though, is that people really have rolled up their sleeve and shown that they can get the vaccine, it can protect them, and it can be quite safe. And that we're at this place right now where there actually is still a lot of great benefit in getting the vaccine now. Usually we talk about November as flu vaccine season. It is good to get your vaccine in November to be prepared. Now, flu is here, but it's not widespread. So what I would say is those who got a vaccine last year maybe haven't gotten around to it yet this year. It's not too late. And of course, you can get vaccines at pharmacies, doctors' offices. Many of them have flu vaccines, even if they don't have COVID vaccines. And also public health often provides vaccines as well.
Thanks very much for that answer. The next question is for Dr. Howard Ovens. How are hospital staff dealing with the demands that are currently on the system?
In the simplest frontline worker perspective, we are doing the best we can. We are Dr. Lim himself was on duty last night till midnight. He's back on duty 8 o'clock this morning. I was on duty till midnight. I was in the office this morning at 9 o'clock. We're all working hard. Some of us are picking up extra shifts. And we are working as hospitals to coordinate the staff that are available, juggling frequently due to staff illness and or absence for isolation, or to provide childcare, which takes some staff off their schedule, and to try and share the load. Also regionally, something that's a little bit new during COVID is that we've seen the introduction of kind of coordination and command tables, which are trying to level the load between hospitals for the most critically ill patients. And that's helping us cope as well. And really, I think that not just doctors and nurses, but all the hospital staff I work with, right from the porters, the cleaners, the clerks, have a sense of a mission in helping the public at this difficult time, a sense of esprit de corps, not wanting to let their colleagues down, and really feeling a sense of satisfaction when you work together as a team to do a challenging job that's of value. And so we're doing the best we can.
Thank you very much. I appreciate the answer. The next question comes from Maria Rosales-Gerp at the Cambridge Times. Dr. Lim, I'll direct this question to you. How critical is RSV within newborns? Should pregnant individuals and new mothers be concerned?
Yeah, thank you very much. Great question. There are lots of infants that will weather RSV just fine and are able to be safely managed without hospitalization or that kind of care. But that being said, you know, the time of the first 2 to 3 months after birth are a critical time where other types of infections can manifest that are very serious. So any kind of fever or infectious symptoms in a very young child really should be evaluated, especially fever. RSV in its own right can cause problems, and we can certainly see problems are either related to difficulty breathing or pauses in breathing or difficulty with feeding. We would certainly, if I had an ideal world, I would definitely not allow babies to get RSV and to get any kind of infections for the first 2 to 3 months. But certainly I do want to send the message that there are lots of infants that do contract RSV and are safe and do not need to be hospitalized. But it's a very important age range that we always look out for because other infections are so important as well.
Thanks very much. And we have another question from the Canadian Press from reporter Holly Mackenzie Sutter. This one's for Dr. Zacharias. You said that you're asking the Ontario government to act on the OMA's 3 solutions. What are the 3 solutions?
Absolutely. So we know that in this time of healthcare system crisis, we need to act very strategically to alleviate the strain. So 3 immediate solutions would be around the doctor shortage, number 1, and that's to license more physicians who have trained internationally, are here in Canada and not yet licensed. We are working with the College of Physicians and Surgeons of Ontario, our regulator, around what a practice-ready assessment would look like so that those physicians could enter the healthcare system on par with those of us physicians who are licensed to work here in Ontario. So that's number 1. Number 2, to catch up on that surgical backlog. We know that over 1 million surgeries, hip surgeries, knee surgeries, cataract and hernia surgeries were really put on the shelf while we were dealing with the crisis of COVID. Nobody's fault, but those patients waiting for those surgeries are getting sicker, coming back to the emergency department, repeat visits to their family doctors, or don't have family doctors. We need to do those surgeries. And so a solution that we're recommending is the implementation of integrated ambulatory care centers to offload the hospitals of these very important but lesser complex, lesser emergent surgeries to deal with those. Lastly, we want to create more hospice beds and palliative care beds and investment in our community care so that we can alleviate the strain inside the hospital. When a patient is sick in hospital and needs to be there for that period of their acute illness, that is extremely reasonable and appropriate. And yet when they're ready to be moved to the community, they find themselves not having a bed to be placed into. And so we need to invest in community care. Some patients can be discharged home and cared for there. Some patients, of course, need palliative beds and hospital beds and long-term care beds. And if we had those beds to move hospital patients into, hospitals would be under less strain, which would have a trickle-down positive effect to less strain in the emergency departments, where a lot of these admitted patients actually sit and are cared for by emergency department teams, which is not the original design either. And so investments there in community care would alleviate the hospital strain. These 3 solutions we think can be implemented immediately and would definitely allow us as physicians to deliver the care that we need to our patients inside a system that is less strained.
Thank you very much. And the next question is for Dr. Vinita Dubey. This comes from Pauline Chan with CTV News Toronto. She's saying Dr. Davila is looking into the need to restore mask mandates in some cases. What are the factors that parents should consider as highest risk to mask their children?
Okay, thanks for the question, Pauline. There's no question that masks work. We know that they work, and we actually also know that children were able to attend school and wear a mask for the most part, and were able to provide some added protection for them and others. And so what we're saying right now is if you are at higher risk for getting very sick from COVID, or you live, work, or spend time with someone who is at higher risk, that may be a very good rationale for you to wear a mask, especially in those indoor places, because we know it's the indoor settings that are the higher risk for spreading some of the viruses. So someone who would be at higher risk might be someone who has a chronic health condition, and it may be respiratory, like someone who has asthma, but it can also include things like heart disease, high blood pressure, maybe someone who's on immunosuppressive medications that weakens their immune system. But we also know by age you are at higher risk. And so seniors we've seen through COVID are certainly at higher risk for COVID, but also for influenza. And as I mentioned earlier, our youngest children are actually at very high risk for getting very sick from influenza. We've heard about RSV. And so protecting our youngest children through masking is also another consideration.
Thank you very much. And another question for you, Dr. Dubey. This one comes from Elizabeth Payne with Post Media. She's asking, we have seen doctors from overburdened children's hospitals pleading with people to wear masks to reduce viral spread in recent days. Is there any way to increase masking without mandates?
Yes, absolutely. I think we can recognize as a community, as a society, when masks can be strongly recommended. And let's remember that, mask mandates were implemented in some places, but were not ubiquitous. And as if once we recognize that we're in this situation now, increasing respiratory viruses, we can all take that measure to wear masks. We can expect, our Chief Medical Officer of Health has said very publicly that a strongly recommended masking may be coming as well. And we can see that with that strong recommendation, mask usage does increase, even without having to go to a mandate.
Thank you very much. And the next question is for Dr. Howard Ovens. You mentioned there may be other options before you go to an emergency department, but what about if somebody doesn't have a family doctor? Should they visit a walk-in clinic or look for a virtual clinic before going to the emergency department?
Thank you for that question. There's a lot of variation in what is available to you by community and region in the province. And rather than making a generalized statement about it, I would recommend that people use the provincial service Health Connect. In the first instance, they'll help you decide if you have an emergency or not. And then in the second instance, if you don't have an emergency, they have a full menu of what's available to you, depending upon where you're calling from. And based on the nature of your problem, is it suitable for a virtual assessment, or is it something that needs an in-person assessment, and what urgent care or walk-in clinics might be available to you in your community. There are some communities around the province which have or are building up their COVID assessment clinics to potentially see some other viral illnesses as well. So there are a lot of options out there, and rather than trying to figure them all out, I'd say call 811 and let Health Connect help you figure it out.
Thank you very much. And Dr. Lim, this question is for you. You talked about the strain on the pediatric system. Are you expecting it to get worse this winter?
Yeah, I mean, we know that congregation indoors as the weather cools down is a factor for viral spread. Traditionally, our busiest respiratory months are February, January, and March. So, it's only early November now. So we all anticipate that it will get worse before it gets better, just because of the seasonality of these viruses and the R factor that's affected by congregation and cold. So yes, I think most of us in the pediatric sector are bracing ourselves for an incredibly challenging winter.
Thank you very much. And Dr. Dubey, I'll ask another question to you. This is from the Cambridge Times. Are we seeing difference in demographics within children in terms of illnesses or vaccination rates or groups being hit harder from the flu?
Yeah, great question. We don't quite have the analysis of the flu cases the same way we did for COVID-19 cases. Nationally, what it has shown though is that 55% of cases of the flu have occurred in those 0 to 19 years of age, so the broad spectrum of children. We do know, though, with COVID, that we did see higher rates of COVID activity among those who were marginalized in neighborhoods where there were lower incomes, more newcomers. We haven't done that analysis for influenza per se, but these viruses do spread more easily. In general, we have seen though with Omicron that there has been because Omicron has been so much more contagious that actually most communities have been impacted by it. But the one other way to look at this is to look at vaccination rates. And we still continue to see, I can talk about in our own city, certain neighborhoods that continue to have lower vaccination rates. And so that is certainly something that we are looking to address in terms of some of the inequities and getting vaccination rates higher in some of those communities, making the vaccines more accessible and available to those communities as well.
Thank you. And Dr. Dubey, we have another question from the Cambridge Times. Are you seeing a particular burden on Indigenous communities in Ontario?
Thank you for that question. I don't have the data for influenza or COVID by particular status related to First Nations, Métis, and Inuit communities in Ontario. And maybe that's something we could ask the OMA to follow up with our Public Health Ontario colleagues to provide you with that data if it is available, because it may not be as well.
Okay, thank you very much for that question. The next question is for Dr. Zacharias. We've talked a lot about the strain on the hospital system and the healthcare system overall due to staffing challenges. How prevalent is physician burnout right now?
We know that physician burnout is incredibly high and extremely prevalent. In April 2021, we surveyed our physicians, our 43,000 physicians in Ontario, and almost 75% of Ontario's physicians said they were operating at a level of burnout. And we see this evidenced by early retirements, family doctors, for example, focusing their practices and not doing the comprehensive family medicine care that they intended because of the strain. We know one of the leading causes of burnout is documentation requirements. There's so much more expected of a physician than what there was. I've been a doctor for 20 years, and with the introduction of electronic medical records, the news that we all welcomed, switching from pen and paper to our computers has really introduced a lot of burdensome time that it takes to do the documentation that's required after every visit. We know the ratio is close to 2 to 1. For every 1 hour of direct patient care, a doctor will sit and do paperwork or computer work for 2 hours. And so can you imagine the more patients that could be seen, the more quality time that could be spent building that trust in a relationship with your patient if you weren't required before the day was out, before the week was finished, to do all of your paperwork. And so we are working with the government. We have bilateral burnout task force team. We have a bilateral forms committee. We know forms are also taking doctors away from that direct patient care. And so there are things we can do. We know burnout is high. We know it's contributing to the crisis that we have at. We know it is impacting patient care, and we want to care for our patients. And so we're committed to implementing some of the solutions to address the burnout that we see.
Thank you very much. And another question from CTV News Toronto, from reporter Pauline Chan. Dr. Dubey, can you repeat your remarks about the 50% of flu cases being in children?
Finding that sticky mute button. Yes, absolutely. Yes, so based on the National Flu Watch summary, they have noted that in the week from August the 28th until October the 29th, more than half, 54% of identified lab-confirmed flu cases were in children and teenagers aged 0 to 19 years of age.
Thank you very much for that answer. And I have another question for Dr. Lim. How can you tell the difference between RSV, the flu, and COVID in children?
Yeah, thank you very much. I mean, they are very different in terms of the population that we are most interested in and in how they present. They may not be that easily distinguishable to the parent at home with their sick child. In general, RSV, as we had mentioned, tends to present in younger children, almost looking like they have an asthmatic attack. They can present with wheezing, difficulty breathing, and it tends to affect children under 2 years of age. If an older person who has RSV, it may just seem like a very minor respiratory ailment. Influenza can present in many different ways, usually with quite a high fever, and a prolonged fever can present with muscle aches, respiratory symptoms, and tends to make people feel quite unwell. Hence the expression "have the flu" or a flu-like illness. And COVID-19, depending on our past 2.5 years, depending which variant we're talking about. But obviously, I think people are very much in touch with the types of symptoms that we get with COVID-19. I do mention on a positive note that in terms of the current variants that are going around, they tend to be a little bit more easily distinguishable, and they tend to cause less of the multisystem inflammatory disorder in children that we were seeing with some earlier variants. So that is a positive thing in that respect. But I think, unfortunately, there's a lot of overlay of these three viruses, as well as other viruses that we haven't mentioned, that can make it quite challenging for parents to distinguish.
Thank you very much, Dr. Lim, for that answer. And we have another question for Dr. Vinita Dubey. This one's again from the Canadian Press. What metrics would you have to see to recommend mandatory masking?
Okay, thanks for the question. I think it's not any specific metric that would say this is the threshold, let's do mandatory masking. What we look at from a public health perspective, from a surveillance perspective, is how much severity of illness do we have among our population, and what is the impact on the healthcare system? And we have certainly seen with COVID that we've had to put in broad public health measures because of our public health or our healthcare system being under attack. And we saw that very, very closely in some of our previous COVID-19 waves. When you look at the indicators, you want to look at it on a population level, and that's why often making mandates or broad recommendations on a provincial level are so important, because they're not necessarily specific to a city or a community, but often represent a broader or widespread activity. And so that may be another metric as well.
Thank you very much for that answer. We have a question now for Dr. Howard Ovens. This one comes from Chris Glover with CBC. Dr. Ovens, do you have a specific example of someone staying away from the emergency department only to wind up in the hospital sicker than had if they'd gone right away? And also, do you have any data illustrating this phenomenon, either at your hospital or the bigger picture, or any sort of numbers associated to the phenomenon of people staying away from the emergency department?
Yeah, thanks for the question. Certainly at a lower level of severity, every shift I see several patients who probably should have, and under normal circumstances would have come in sooner. Last evening, I saw a patient with a large painful abscess that had been present for about 10 days, and he knew he was probably going to need some intervention, but just didn't want to deal with the long waits. In his case, it was just discomfort. I've seen people with musculoskeletal injuries who've been putting off coming in, who end up needing a cast or in some cases even some surgery, who normally would have come in the day of their injury and have waited hoping things will settle down so that they don't have to deal with the emergency department. Not always because they don't want to wait. Sometimes they don't want to burden us. Actually, 2 weeks ago, I saw a woman who was unable to walk, had an ankle injury that required surgery, and had been home for several days with her husband looking after her, unable to walk because she didn't want to burden us. I've seen lacerations that should have been sewn shut that no longer could be because they'd waited several days. At the more serious end, or potentially serious, I recall seeing a woman who'd had several TIA or transient stroke-like phenomena over a period of several weeks, and just didn't come in until a friend she shared the story with said, "Are you crazy? You better get yourself to the hospital." Luckily, it didn't progress to a completed stroke. We've all seen ruptured appendicitis that would have been simpler to repair earlier. At the more serious end, also cancer cases that have had a delayed diagnosis. I have seen a couple of instances of that where either emergency wait times or general pandemic circumstances have led to a delayed diagnosis. And there are some, I don't have any personal data. There have been some publications, including, I think, in the Canadian Medical Association Journal, looking at cancer cases presenting at a more advanced stage where treatment is more complex. So I think it is a real phenomena. Sometimes it just leads to discomfort, but it can lead to more complicated treatment and sometimes worse outcomes.
Thank you very much for that answer. We have a question now from reporter Crystal Hewitt. Dr. Zacharias, I'll direct it to you, and maybe Dr. Dubey, you may have thoughts on this as well. But it is about Peel Region, so perhaps the reporter could follow up with Peel Public Health afterwards. The question is, Peel Region was one of the COVID-19 hotspots. So wondering if someone can speak to the specific concerns around Peel Region as this triple threat of respiratory illnesses approaches, and perhaps how pressure in hospitals can be alleviated locally.
Sure. Yes. Yeah, I do think maybe following up specifically with Peel Region, but in general, we know that here we are heading into winter and the rate of viral illnesses will increase. We know the flu season was severe and it's earlier. And so we are already seeing flu cases, and yet we know how effective vaccines are. And so first and foremost, we want to be prepared by encouraging our population to get vaccinated, to get their flu shots, get their COVID boosters, and also to avoid going out into public if you're symptomatic. Also, I mean, we do know that over 1 million people don't have family doctors, but the ones that do, this may be a time to reconnect with your primary care provider, to optimize your blood pressure medication, to have a check-in on your diabetes and how you're managing your chronic medical conditions, because preventative care and having that close monitoring of your multiple medical conditions can prevent you from getting so sick that you're requiring emergency care. And so as we head into winter, as we know this triple threat of COVID-19, the flu, RSV is going to mount the requirement for emergency services because of increased respiratory illness. We can all do our part in looking after those aspects that that we can. Mask mandates aren't here now, and yet we know that even masking indoors in crowded places with vulnerable populations can be very preventative when it comes to getting sick. So these are really some things to keep in mind. I can hand it over to Dr. Dubey if you wanted to add to that answer.
Yeah, I think that's a great answer. I think when we talked about hotspots before, a lot of it was before we had vaccines. And we have certainly seen that we got really strong uptake of vaccines across the province. And then with the advent of Omicron being so highly contagious, that kind of specific hotspot epidemiology is not quite the same. Now, Public Health Ontario does post related to COVID-19 wastewater surveillance data. And if you look at the GTA, it's GTA in general, which would include Peel. It's very similar to some of the other regions as well. And I think we have to think about, when you think about urban centers or large spaces like Peel, it's the activities, it's being indoors, it's crowded places around a lot of people that is how viruses tend to spread.
Thank you both very much for that answer. I'm going to ask reporters now if they have any final questions to please put them in the Q&A because we only have just a couple moments. If we don't get to them, you can email us at media@oma.org and we will follow up with you. And I'd like to thank all our panelists as well who did a tremendous job speaking and answering all these questions that we got from the media today. Dr. Zacharias has some closing remarks, so I'll pass it over to you.
Thank you, Emily, and thank you everyone for your insightful questions. Also to our expert panel, to Dr. Dubey, Dr. Lim, and Dr. Ovens for sure, for lending us your insights, your medical expertise, also the hard work that you are doing on the ground in order to care for Ontarians. And so I do want to stress that it is time to fix the cracks in our healthcare system. We have compassionate, resilient, high capacity healthcare providers showing up at their workplaces every day with the intention to care for patients. And yet our healthcare system has cracks that have been exposed as a result of the pandemic strain, and there are chasms really now, and we're feeling it. And we need to be caring for each other, especially our most vulnerable. So this is the time of year, first and foremost, to get vaccinated, your flu shot, your booster for COVID-19 if you're due for that. And then also top of mind for us in our relationship with government is to continue to urge the implementation of our top 3 solutions. And I'll just briefly outline them in closing. That's licensing more foreign trained physicians, also moving ahead urgently with the creation of integrated ambulatory centers for those less complicated outpatient surgeries and procedures to ease the burden on hospital and to reduce the wait times. And lastly, to create more hospice beds, palliative care services to improve not only the patient experience, which is really important, support caregivers, and to reduce pressures on the emergency departments. So thank you so much for your time and your attention today. Take care of yourselves, and bye for now.